of how this public-private collaboration can drive results toward a better patient care. We hope that this example will inspire you to accelerate the digital transformation and data management in your organizations. So before moving to the first presentation of Dr. Cosio, I would like to have several reminders. The first one is for the attendees. So for those who are joining virtually, you can send your question by clicking the Q&A tab on the right side of your screen. For those with us here in person, you can send your question by first downloading the Congress app, and once logged in, click Q&A from the home screen and select this session. And finally, to get to know more about the presenters, you can view their profiles in the Congress app. And finally, the reminders for the presenters. We will organize ourselves in the following way. So first, we will have Dr. Cosio for 20 minutes. Then we will move with the presentation of Dr. Feu for also 20 minutes. Then Dr. Velasco for 15 minutes. Then we will open a session for 15 minutes with some specific questions. And finally, we will have an open time for the question from the audience for approximately 10 minutes. So with this, I think it's time for Dr. Cosio to start presenting the Health Outcome Observatory.
Thank you, Matthias. Could you hear me properly? That will be much better. So it's a fantastic opportunity to me to present all this project that is very inspiring, and as Matthias says, an opportunity for health, all the ecosystem with the private-public partnership. So the name of this project is H2O. Let me see if, like the water, is the Health Outcome Observatory. So to introduce this project, I want to know, and please raise your hands, if you are patient. Good. And you will be patient. Great, fantastic. Then we all on board about this project. This project is about that, about what matters to the patient and how we can improve the healthcare system being a patient. So the outcomes that matter to all of you is exactly what we are looking in this observatory. We are trying to organize the data that come from the perspective of the patient to transform the healthcare. So to understand better this project, I will start with this short video. Let's see if it works. I don't know if the IT team could help me with the video. Let's wait a little bit. If not, I just will explain what it is about. Yeah. It's always happening in these digital transformations conference that this kind of thing happen, no? Happened to me always because I'm an IT director.
Health data is an essential resource. Health data should be accessible to all stakeholders. It should be accessible to health data is an essential resource.
So you want
it has the potential to all stakeholders. It has the potential to inform facilitate and their healthcare side. It has the potential to inform is better care, better conversations, and more efficient for their healthcare and more efficient for the sustainable better care for individuals.
Could you start again, please? Could you go to the beginning? Yes, we can do it. There you go.
Health data is an essential resource. It should be accessible to all stakeholders with a legitimate interest, including patients. It has the potential to inform and facilitate better conversations between patients and their healthcare providers. The result is better care for individuals and more efficient and sustainable healthcare systems for the entire community. At this time, There are only very few examples of systematically measured patient-reported outcomes being used in individual clinical care. No widespread approaches exist to address this shortcoming at scale. 23 world-leading institutions, including university hospitals, patient organisations, and industry partners, are joining together to design the healthcare infrastructure of the future. The H2O Project is the first ever attempt to collect and incorporate patient-reported outcomes into healthcare decision-making at an individual and population level across multiple locations in Europe. Within 2 years, H2O will set up independent observatories in Austria, Germany, the Netherlands, and Spain, as well as a European umbrella observatory. The observatories will have an initial focus on diabetes, inflammatory bowel disease, and cancer. H2O is being established such that it's capable of scaling up to more countries and more diseases in the future. Health Outcomes Observatory, making health data as an essential resource, available to all.
Fantastic. Thank you very much. Thanks, IT team. Well done. So yeah, we always remember IT when things go wrong, when everything goes well. No one remembers that it's thanks to them. Then thank you. So going back to the project, I will spend 2 minutes to explain exactly what it's about, what we are collecting, because outcomes, health outcomes that matter to the patient, it's a lot of words that maybe you are familiarized with that, but probably no. So as I say, if you are or you will be a patient, it's very easy to know what we will collect and why we will collect, for example. If you have a hip fracture, if you have broke your hip, probably the doctors are very worried about consolidation of the fracture and other things. Probably the healthcare providers are worried about the waiting list. Probably the regulators about how much it will cost, how much activity the healthcare provider perform. But you, what you need is to walk again. It's easy like that. Then someone asks to you in a standardized way, are you walking again? Did you recover your life after this fracture? Then this is about, the project is about to collect this outcome that matter to the patient. And not just to collect, it's just to do something with this outcome, what we're gonna do. So the second slide is what the participant of this consortium, and as you see, is a large numbers of university hospital, but also other private companies, and that is the beauty of this project, because all of us, all the stakeholders, all the ecosystem need these outcomes to take decision and to improve the healthcare. That now is the opportunity to work together to get them. So why? Why to have to do that? If I speak with a clinician, probably if some of you are clinicians, say, but we ask this question to the patient in the consultation room. We already have these things. Yes, it is probably that you ask, but you ask from your point of view. This gives the opportunity to empower the patient, that the patient can answer in a structured way what mattered to them and what was the result for them. Then basically with all that, the health providers will have a standardized way to compare and to see what is the more efficient and the better way to perform the healthcare. This is like, I like this figure here because it's like the piece of the puzzle. We measure in a lot of things that are important, a lot of things that are valuable, a lot of important outcomes, but this is what we're really missing in a big scale. So why we are doing that? Basically, to create this observatory of these outcomes would provide better quality to the care of the patient. How will it happen? Basically because with the standardized health data, in all the ethical and social responsible way, we can compare and find the better way to do things. All this idea will have like some stage. So the first is to set up these observatories. Once we have all this data, we start to building a community of learning all of us, all the providers and all the pharmaceutical companies will see the result, will ask questions about the result, what it is happening, and we have more questions and more research to do to improve. Then it's all this learning community. Then it will generate a culture change. I speak about values-based healthcare. That is what is based, all these observatories based in this theory. It's something that required a very strong culture change. Then it is difficult to do that when we don't have results to show. Then at the end, what we want with this project is that we can't make and we can't generate all this culture change. So I think that this is the more important slide to understand how it will work. So I will go slowly. Here down, as you could see, is the kind of records of kind of outcomes that we're going to collect. Of course, we focus in the patient-reported outcomes because we don't have that yet in our healthcare system, and we are focusing that. But it's also other data that come from the patient, from the devices and from other things that also tell us if the patient are recovering or not, like a proxy of the answer of the patients. So also we have the clinical reported outcomes that are very important and matter to the patient as well. For example, there are some complications, the leg on stay, the survival. These kind of things can come from the clinical reported outcomes. It is already in our electronic medical records, and we want to enrich all this observatory with this data. And there are also some data that is outside sometimes the healthcare, sometimes no, but also that we need to collect and we need to put together to understand better the picture of the situation of the patient is the data from the registers. That the advantage that have is structured data, and there are some clinical conditions, some teams that have been following this register for such a long time that the idea is to take advantage also of that. So with all this data, starting from the patient-reported outcome, is also in a stage. We will start from patient-reported outcomes. We create 4 observatories. The project proposed these 4 countries to start. It's Spain, Germany, Netherlands, and Austria. So these are national observatories that will fit the European observatory. The European observatory is kind of an umbrella that dictate what are the interoperability standards, the outcome that have to collect, and also that provides some reports for the feedback. So under this umbrella, all these other observatories would work to enrich all the data. So as you see in the video, the observatory starts with 3 pathologies: diabetes, inflammatory bowel disease, and 3 types of cancer. We start with breast cancer, lung cancer, and also some hematologic cancer. So all these observatory have maybe in the next slide it is more clear. Let me go back. So the idea is that all these stakeholders that you see on the top, the government, the healthcare providers, the patient organization, the regulatory agencies, academia and research, and industry could use this data for the good of improving quality of the healthcare. This is another new thing in this project, that usually the data is in a specific sector, and just this sector can use for take decision. Now what we want is democratize all this information. So this is more about how it works. Basically, what we are doing now is setting the legal entity. The legal entity is an independent association. What I try to say with independent association is not private, is not from the companies, is not from the public sector. It's basically with a board where everyone could be represented and could take decision in the more neutral way with these outcomes. So we decided the common model to standardize the data and also the questionnaires that we need to give to the patient. We are in this stage in the national observatories. So the Pan-European Observatory now is identify what is the technology that we need to guarantee the governance and the interoperability of this data. So as I said, in the first month, we start this project in October of 2020. 2020, yes. So we decided all the framework, legal, ethical, and technological framework. All the groups of the different clinical conditions are working, decided with set of outcomes. Also, there are a specific work package working in the technology that we need to collect all these outcomes and how has to be the flow, the information, and the infrastructure to make that possible. So the proposal is that the healthcare providers get the data with a level of individual patient. When it go to the National Observatory, it will be aggregate or anonymized. And when it go to the Pan-European, it will be aggregated in a federal way, but we can get information, but we not go at the level of the patient, that it ensures the RGPD law. Also, we provide feedback with reports. Reports to who? Reports to the patient. The patient has to know how is his health, her health, compared with other patients, and how is the evolution of their own pathology. The report also go to the clinicians, so the clinicians can see what is, in which point is this patient compared with other patients, but also compared with another sample from his group of patients. Reports also go to the healthcare providers, also go to the authorities to know how things are going. So all these things is just possible because, as I said, the collaboration of public-private community. Basically, we need to make these observatories sustainable in the time. Then to make that sustainable is the data, and the quality of the data and the information could be important for the stakeholders, that they can see that is interest in this information. Also, I didn't mention before, but the framework of this project is in SANIMI, Innovation Medicine Initiatives, that it's get money from the industry, but also for the European Commission to develop that. Then, of course, the lead company here is Takeda, but there are many other companies involved, like Novartis. Then all these multi-stakeholders give us a very good vision about how it has to be. Then also we want to do is not to compete with initiatives that are already running in our countries, in our hospitals, in Europe, and the European Union in general. So what we need to do is use all of them as a leverage to have a bigger result, to have a bigger and more consistent project. So my last three slides is basically that. To the healthcare provider, is easy to know now what it brings to us. No, it's an integrated and more holistic view of the patient health status. Also, to have this structured information can make us to take better decisions. We can also it could be also the start of the telemedicine, the remote follow-ups. In a personal experience, for example, we implement all these health outcomes in a stroke, and we reduce the face-to-face visits 40%, because basically the patient answered the questionnaires and they were so good. The doctor review, and just with a call, they say, okay, keep going and keep doing that, and we avoid all these face-to-face follow-ups. Also, benchmarking is very important. All of us are doing the things in a different way, and all of us think that is the best way. Then probably some of us are not doing the best. So the benchmarking gives us the opportunity to compare and to see what is the more efficient way in taking into account the results for that matter to the patient. So of course, to becoming a community that guarantee the patient engagement and the sharing decision making. To the patient, of course, that they have their own information is quite a gain for them. They can empower seeing that they can't be participating in the decision. They can ask, I prefer this treatment than this one. I see that the patient that go with this have this result. I want that. I want this or that. And it's basically to have their voice in our system, in our from our consultation room till all the healthcare system. So basically, the patient have benefits because, of course, it will improve the quality of life. The healthcare professional, because they will have objective outcomes to see if they are doing the things good or not. Patient organization is another thing that in different projects is not very good engaged, but basically here, if the patient organization have all these results, they have also objective indicators to know how are the population and to go and speak with the authorities about what they need. Health authorities providers to see how we made this system sustainable, and research and pharma companies to help us to keep improving the new treatments and the innovation for the patient, basically. So this is a part of the list, that part of the consortium. We start to do a collaboration with all these initiatives, as I say, because we would not want to compete. We want to leverage and to work together to make that a reality. Thank you very much. Then let's go with the question later.
Thank you very much, Dr. Cosio. Now we give the floor to Dr. Feu, who will talk to us about the value-based healthcare and how to drive it from theory to clinical practice.
Thank you. Good afternoon, Mr. Chairman, dear colleagues. First of all, I would like to thank Novartis the kind invitation to participate in this session. In my talk, I will show you how we moved from the theory about value-based health care to a practical application in a tertiary hospital by implementing a standard set of outcome measures according to the methodology of H2O, International Consortium for Health Outcomes Measurement. This project was performed at the Hospital Clinic of Barcelona, a teaching hospital in the city of Barcelona that provides tertiary healthcare to an estimated population of 1.5 million. Value-based healthcare is a model where the most important are the measure of the outcomes that matter to the patient relative to the cost of the service delivered. This model seems to improve the efficiency of patient care. Patients achieve better health and more satisfaction, and the general population also increases its health. Finally, a reduction in cost of the service delivered is expected. However, it seems that to put into practice is more difficult than expected. So, a high commitment of the hospital is needed to shifting from volume to a value for patients. H2O standard set for inflammatory arthritis was identified as a great opportunity to be the starting point for the implementation of the project of value-based healthcare. As you know, H2O standardized the set of variables to be collected for inflammatory arthritis and give the standard set of clinical and patient-related outcomes. This standard set was chosen because we want to ensure the feasibility of the project with the implementation of an affordable standard set. In addition, we had an enthusiastic response from healthcare team involved in the treatment of patients with inflammatory arthritis, and also they had a previous wide experience with quality of life test. Inflammatory arthritis is a chronic disease affecting mainly young patients who are probably more adherent to new technologies needed to develop this project. This slide illustrates main phases in the process of the implementation of our project. And the first step was create the working group. A number of healthcare professionals involved in treatment of patients with inflammatory arthritis were included, mainly physicians and nurses. We also included members of the Department of Quality for giving methodological support and coordinating the activities of the working group. In this starting point, it was essential to have a clear leadership from a clinical team to ensure the success of the project. Next steps were process mapping, identification of improvements and indicators. An important and essential step was the creation of data set according to the methodology proposed by HOM, and including demographic and clinical data, laboratory test results, and patient-related outcomes. With this work, we have to face the work of adapting IT tools, mainly into issues. First, creation structured data forms to collect the data from patients, and also second, to create an application to get the quality of life tests from patients. With this information, we return these results, with an analysis, specific analysis, to the healthcare team in order to easy the decision-making process. Before going on, we have to consider two main challenges for this project. In our hospital, as I think it happens in other hospitals, we have digitalized medical records with no or few structured data, and only few hospitals have all of clinical and patient-related outcomes coming from structured data. The second, according to a strategic decision, clinical and patient-related outcomes must be built inside the health information system of the hospital, not outside, inside of the health information system, incorporating all demographic and clinical data, laboratory tests, and the results of quality of life tests. It was required high effort from the information team to adapt the IT tools to incorporate these clinical outcomes inside our hospital information system. Next, we do a comprehensive assessment of the process with a description of all activities. And for each one, we describe who was the responsible for this activity, how to do that, and where and when to perform this activity. We are convinced that process mapping is highly recommended because it allows identification of possible improvements of the process, and it provides to team with a better knowledge of the activities around the inflammatory arthritis. An essential step in the project was to create a standardized data set for inflammatory arthritis according to the standard set suggested by HOM. This data set had full details for each variable, including description of type of data, timing to be collected, healthcare professional collecting the data source, definition of the algorithms needed to calculate the complex indicators of activity index, and what kind of quality of life test we used for patient-related outcomes. In the right panel, you have a real but a small fragment of this big data set according to HOM methodology. An important, or one of the most important developments in this project was to construct a structured data form allowing to collect the patient clinical and patient-related outcomes. It was important that there is a common entry of this data for physicians, nurses, and any professional involved in the treatment of patients with inflammatory arthritis, avoiding in this way registration of duplicate data. It's essential that this form should be user-friendly, not time-consuming for clinical team, in order to ensure that these professionals will use this e-form or this structured data form. In the right panel, you can see a fragment only of this e-form created specifically in our system, inside our system for inflammatory, to collect all clinical and patient outcomes of inflammatory arthritis. This e-form allows registration of clinical data, capturing laboratory test results, capturing results of quality of life tests, and to calculate activity index. The other important development during the project was to build a web and mobile application for quality of life test. Physicians and nurses may prescribe a specific quality of life test for an individual patient, fix timing to arrive this test to the patient, and this application warns the patient when a test is pending to answer. Patient can answer the test out of the hospital, even before the visit with the physician or the nurse, and by using different devices as computer, tablet, or smartphone. A main characteristic of this application is that patient-related outcomes are immediately available for healthcare team. And also, we have graphically presented these results for a long-term follow-up of the patient-related outcomes. In each visit in one individual patient, healthcare team may access or may have information about inflammatory activity index calculated from a combination of clinical data, laboratory test results, and the quality of life results from patient. In the bottom panel, you can see an example of this information, and for each inflammatory activity index, you can see a figure that represents the value for this index and with information about the level of activity according this value. But to ease the decision-making process, we have built a graphical presentation of this activity index and the time progression to visualize the evolution of the activity of the inflammatory activity of the disease. Using as you can see, using a commercial business intelligence software, we give additional information to healthcare team about their patients. Here you can see an example of the long-term follow-up of clinical and patient outcomes. In the left panel with laboratory tests, middle panel patient-related outcomes, and in the right panel activity index. We think this may be useful to support the decision-making process during the visits of the patient. Sometimes physicians and nurses need population data for research, for audits, or to assess the efficacy of any therapy. This is the reason to build this kind of dashboard incorporating the population analysis of health outcomes. In the left side, clinical staff has available different options. They can select more than one, and then the evolution, the time progression of these outcomes are shown in the middle of the dashboard. As shown in my presentation, we developed a digital transformation in order to build structured data forms that make easier to clinical data registration and real-time capturing laboratory data and patient-related outcomes. We built an application, a web and mobile application for quality of life test prescription and answering on patients, and this information is all of them integrated in the information system of our hospital. Activity, as previously shown, activity index are also included. Finally, we increased the information for clinical team with a graphical presentation of individual patient follow-up or a population follow-up. Since it has proven the feasibility to implement a standard set of HOM for inflammatory arthritis, this prompted us to work with the implementation of further HOM standard sets in our hospital, like hip and knee osteoarthritis, breast cancer, macular degeneration, and lung cancer. In addition, we are working to develop new standard sets according to HOM methodology for other pathologies, like for other processes like liver transplantation, severe asthma, and chronic obstructive pulmonary disease. We think it's important to do benchmarking with other hospitals working with the same methodology and to establish collaboration with the hospital network. Finally, in short time, we must incorporate the cost analysis in our project. I think this is a great opportunity to thank the team for the Department of Quality of the Hospital Clinic of Barcelona for the hard work, commitment with projects, and enthusiastic dedication to improve quality. Thank you very much for your attention.
Thank you very much, Dr. Feu. Now it is the time for Dr. Teresa Velasco, who is going to talk about the Biome project.
Thank you so much. Thank you to the previous speakers. I think it's a pleasure to be here with familiars, friends, and also colleagues from the healthcare ecosystem. Also with the people connected virtually today that we are also trying to follow up with you. So thank you very much. I think there is a huge ecosystem with projects regarding digital health, PROMs, PREMs, a lot of digital health taking place. And of course, we as a biomedical company are thinking, how can we put our efforts, how can we direct our strategy in order to support all this value-based healthcare that is taking place in the ecosystem, and what should be our role. So my objective in this session is that you understand what we are trying to do in order to build ecosystems and in order to bring value to those ecosystems that we're working in. So here you see that our global presence is huge. Of course, we are one of the top biomedical companies, together with others that we are happily and proudly collaborating with. And the thing is that when you have an international presence and you are able to see the challenges, the needs of the healthcare system from regional, from local to global, when you have this global view, you realize that there is something that you can do that goes beyond what a specific provider is asking you to do, and also that some experiences that we have from other countries might contribute to solve all those challenges that we are experiencing at the clinical level. So what we did is establishing a network of centers, a network of hubs for innovation within Novartis and our stakeholders in different countries that you see here represented. So our top 11 countries, and Spain is one of those, launched this hub, which is going to grow in the upcoming years. We are connected through those hubs, and we are sharing innovation projects. We are also sharing challenges and those initiatives that can be scaled up from local, so from local to global, or from global to local. Either finding needs on the healthcare ecosystem that we might cover with solutions from other countries, from other experiences, and also some of those digital solutions, some of those value-based healthcare experiences that we detect here can be scaled to other countries. So what we have here is a representation of top projects in Europe that might sound familiar to you, some of them. For example, how with the NHS we are co-creating health technology solutions, especially now with population health collaboration with the healthcare ecosystem, in which the information systems are clue. So if we want to build valuable population health agreements and collaborations, in which what we do as a biomedical company is provide valuable products and innovative products together with service to the healthcare system, we need to promote the measurement of value, as Dr. Cosio was explaining before. So Dr. Cosio was telling us, without the PROMs, without the health observatories, we couldn't be able to measure what we are doing, and without those PROMs, we couldn't be able to empower the citizen in the last instance. So that's exactly what we are trying to do with the NHS, and we are trying to collaborate with them in solving the identification of problems and then problem solving with testing and scaling up, especially for information systems and value-based healthcare. Same with France. We have a hub specific for the role of data and artificial intelligence, how we can implement those data solution-based or digital solutions or artificial intelligence within the healthcare system. We have here in Spain the hub dedicated specifically to healthcare technology solutions, and we are working in some of the examples that we will cover later and during the question session. And some of the others, something I wanted to reinforce is what we are doing in Germany. You know, the DIGA legislation in Germany, which now will be adopted by France with its own particularities. But what we are doing there is helping the ecosystem to grow in digital therapies. So basically what Germany is doing now is reimbursing digital therapies, not just by promoting the use of digital healthcare, but also by reimbursing those digital apps that are served to the patient and that are measuring those KPIs, measuring results on the population that are being used by the healthcare system and also reimbursed. So it goes beyond, and what we are doing in Germany is trying to, put our expertise in starting to supply those digital therapies and collaborate with local startups in order to promote those new digital therapies within the healthcare ecosystem. So now that you've seen examples, we wanted to define with you what is bringing value to the ecosystem through Biome, through this network of ecosystems that Novartis is trying to put together. So we want to work together with different agents of the ecosystem. So this is you, public and private institutions, of course. So we work with everybody in the healthcare ecosystem, not only with providers, but also with payers, with startups, with SMEs, with all kind of agents in the healthcare ecosystem to put data science and digital at the benefit of patients. And this is because we want to be a reference of partner, a partner of reference in the healthcare ecosystem, specifically for the digitalization of the healthcare system. And this is how we work. In order to be able to generate an impact, we decided to put a methodology in place. And the methodology is that we don't work directly with solutions. So if Yolima, Cosio today, or Dr. Feo, if they came to Novartis and they say we had the perfect solution for the healthcare system, and they explained it to us, and we are collaborating with both projects that we're presenting today here because we consider they are valuable, it wouldn't be enough. It's not anymore about the solutions. Now it is about the problem identification. So which is the need that those doctors are trying to cover with this solution? Is this need something that is shared within the healthcare ecosystem? Are they trying to solve a local problem? Are they trying to solve a regional one or a global one? Is it something that can be reproduced? Maybe it's not scalable. So I am sure that some of the things that that can be presented in digital healthcare ecosystem right now are not so easy to scale. So not a single app, even if it's a really good one, can be implemented in any of your hospitals in 2 days' time. There is no escalation available. There is reproducibility available. So it is easier to reproduce than to scale. So what we're trying to do now is focus on the problem, try to define what is the impact for the patient, what is the impact for the healthcare system, and once we have defined the problem, we will identify the best partner to solve this problem. This is together with hospitals, potential startups, potential providers that might help us in finding the solution. If there is nothing in the market that can solve it, then we can co-create a solution together. We co-create, we pressure test the solution. If there is something in the market or there is something in other country, we will bring it here and we will pressure test it. If it works, we can reproduce and try to scale. If it doesn't work, we would be pivoting the solution in order to be able to implement it in more than one center. So we have an ambition on getting to more and more people, not just staying on the pilot phase, but also trying to face that digitalizing the healthcare system is a huge challenge. And it cannot be solved only by us. It cannot be solved only by a single hospital, and maybe it cannot be solved only by a single healthcare system. We need to put our efforts together in order to make it possible. So here you see the result of the projects that we are working with. Right now we have more than 3 active projects in neurology, dermatology, and ophthalmology, 4 in oncology, and we have open innovation challenges. Those open innovation challenges are strictly to define needs on the healthcare ecosystem. And here we have EIT Health. I see the president of EIT Health is in the session. So thank you very much, because together with EIT Health, what we are trying to do is defining the needs of the healthcare system before we find a solution. Without need, there is no solution that can be applicable. And then we are trying to participate in the ecosystem beyond providers and beyond payers. So we are engaged with some initiatives that you might know, like the Valley in Madrid, EIT Health you see here, Barcelona Health Hub, or the Collider. Having said that, specific examples that we wanted to share with you. We have a specific one on, for example, an app, a gamification app, in order to follow up prompts in a way that the patient doesn't have to relate through a questionnaire, which is the quality of sight that they have. This is for macular degeneration. So they just play with the game, and with the way that they play with this game and how they interact with their mobile phone, they are tracking prompts. So this is a follow-up initiative that doesn't require on a questionnaire. This is something that we saw is needed. How can we follow up patients that are being treated with macular degeneration, edema? And we thought, why not? Why can't we help patients in reporting their prompts in a more gamificated way? So this is working, it's clinically validated, and it's being implemented in some countries, including Spain. And last but not the least, we have, for example, now a project with a hospital here in Barcelona, where we are validating and pilot testing a solution for AI in image recognition for skin diseases. And it's not for a single skin disease, as many others that you might know. It's for a huge variety of skin diseases that can be diagnosed by this image recognition tool. And it is not an app for patients. It is an app to help primary healthcare professionals sending or referring those patients to the specialized care at the hospital level, because we saw that the need is there in how the referrals of those kind of patients are done from the primary healthcare system to the hospital system. That's something that might seem quite simple, but we've seen so many apps so far that are trying to help final users to identify skin disease by image recognition, and this was one of the discoveries that we were doing when we were doing the problem identification. We discovered that it's about referral from primary healthcare and hospital. Now we are validating this tool in order to see if it works. If it works, we will try to scale and reproduce in other places, but we are compromised with the need and not any longer just with the solution. So thank you very much, and I think it's time for questions.
Thank you very much, Dr. Velasco, and congrats to the three presenters. You are excellent in content and in quality in terms of time. You are very timely because we are exactly on the schedule, so thank you so much. So now it's time for the Q&A, and in order to warm up the ecosystem of this room and the virtual ecosystem, I will send 3 questions to the same one for each of the presenters, and after that we will start with the Q&A from the audience. And remember, for those who are virtually, you have to use the Q&A tab on your right side of your screen, sorry. And for those who are here, you should download your app, the app in your devices, and then send the question, because I have here a really nice iPad and I will check the question from this device. In case you want to use the old style, you can also raise your hand and we will open the discussion. So all the ways are open and perfectly available. So to warm up the environment, I will send the first same question for each of you, and I suggest to start with the same order of the presentation. Okay. So the first one is for you, for Dr. Cosio. Is the following one: which are the main barriers you found in your day-to-day to implement your project?
A lot. How many time do you have? Anyway, it's a complex project, as you see. Then more than likely, some of you think the more difficult thing is legal problems to share data through different countries. It's the RGPD regulatory things difficult. It's one of them, yes. Another could be always how you gonna share data with private sector. It could be one of the main. It will be acceptable, because one thing is that it will be legal, another thing is it will be acceptable for the community. And this is one of the challenges, yeah, you're right. But what really, I think that is the big barrier is how to do the cultural change at the point of care. Because all these things sound fantastic and complex, but imagine that we find and we finally do these observatories with all the legal, all the ethical, all the symptoms of the community, and empty of results, because the patients are not convinced or are not following these questionnaires, for example, or the clinicians are not using that with the patient. Then I'm sure that you're very familiar with that. When you start to implement value-based healthcare, the main challenge is to change the culture of our clinician and our patients. Because basically, we don't make all this outcome as a tool of care, no one will be interested in that at the end. And if the patient doesn't follow in it, the patient are not thinking that it's important to follow in that, and the clinician are not recommending that at the point of care, at the end, we're going to have a rate of response under 40%, like happened with many research, as you know. Then if it's not a tool of care, and we have this low percentage, we cannot take decision with that. What happened with the other 60%? If we're lucky. What happened with all these 60% of the patients that didn't answer? Did they recover? They do not recover. Could we evaluate a technology with just 40% of the results? Then I think that the main barrier is that you see all these, we're thinking in the technology, we're thinking in the legal framework, we're thinking in many things, but what really hard challenge is in the clinical provider, in the relationship with the patient. And I think that is something that we need to take into account for the success of this project, is how we're gonna tackle all these barriers, and how we're gonna change that and becoming an opportunity to make that real.
Thank you so much. And now, Dr. Feu, same question. What are the main barriers you found in your project?
Yes, in the first we have problems to build the structure data form and to get the patient outcomes using the quality of life test. Once we have solved this problem, and now I shown you that we solved these difficulties. Now we think that to expand the project in our hospital, we need the commitment from the organization in this new model of value-based healthcare, and the provision of resources to make it possible.
Okay. And Cesar, what about Bio? I don't know how you want to approach the question.
Makes sense, thank you. Well, I think it's more or less the same. I would say we tend to fall in love with the solution. We fall in love with solutions, and we forget about the purpose of what we are doing and the need that you were commenting on. Like, what is the need? As Dr. Cosio was saying, the need of the patient lately is, I guess, the route that we need to follow, and it's the map that we need to follow. So in terms of resources, I would also say there is a lot to do with stop doing. So resources are limited, but we are also investing those resources sometimes as a healthcare ecosystem, and this does not only has to be with biomedical companies, but also with providers, with payers. How many processes that we are using are not value-based healthcare? How much are we investing in stop doing those? And last but not the least, I would say there is a lot on change management to be done. So it's not only about resources in terms of budgetary resources, but also talent resources, and how we are investing on talent in order to make those projects like Biome feasible, or H2O, or those experiences that you have in clinic. I think talent is also very, very important, even more than economical resources sometimes.
Okay, so now we go to the second one, to the second similar question for all of you. So, Dr. Cosio, how can we make this project scalable, your project?
That is cheating. I'm always the first one, and I don't have time to think. Anyway, no, we think about, of course, before, because also an observatory just with 3 kind of pathology in 4 countries is not what we want to. We want that all clinical condition will be included, that all hospital, primary care, and all the providers have the opportunity to participate in this, and also that different countries from the European Union will participate. So our idea is that slowly we're gonna include all these other providers and these other countries, and will really facilitate the scaling up of this project is the standardization. So what is more difficult is when you don't know how you are measuring, what are you measuring, then to put everyone to collect the same things, because it's not going to happen if you don't have a very strong standards. So now that we are deciding that we know what set of outcome we're going to use, what kind of common data standards we're going to use, with all kind of things, it is make easier for different partners to participate and to get on board for this observatory. Then this is the way how we want to scale it up, but basically to everyone is welcome to join the consortium.
Really nice message. So now, Dr. Feu, how can we make scalable your project?
Yes, I think healthcare professionals in our hospital and also in other hospitals of our country, at least of our country, they are expecting to work with patients and with what is value, what matters for these patients. And then I think the project and the implementation of a standard set of action is possible to do in any hospital, but they need to work with the same methodology, with the same set of variables, and we have to work the same way, and then we can do benchmarking and collaborate in a hospitals network.
Great. And now, Dr. Velasco, what are your thoughts on making scalable the projects that Biome is doing?
So in order to reply to that, I would ask the question to the public. Definition of ecosystem. Does anybody know a simple definition of ecosystem? So the definition of ecosystem would be a system of systems. And by definition, escalation is within a single system. Scaling something with a system is easier. I mean, I am sure that within Valdebron, Dr. Cosio project can be implemented. Also, Dr. Feu project within clinic, you have some ideas on how to implement it hospital-wise. When we talk about the ecosystem, for example, the Catalan healthcare ecosystem, implementing the same project in different providers, then it gets more complicated. I would say it gets even impossible, to be honest, coming from the healthcare ecosystem. But it is reproducible or not? This is the question I would do to myself. And this comes from a really good colleague in Medtronic, Germán Gutiérrez. And what he says is that in the healthcare ecosystem, you can reproduce good projects, but you cannot scale them up. So if you're prepared for that, if you're prepared to reproduce them, and you know that you will have to adapt them to the different casualties of the different places, the different regions, the different providers, then you are prepared. But it is too much difficult to scale, depending on which project we are talking with. So there is always an investment of time, resources, and talent when it comes to scale digital solutions. And scale doesn't imply all those resources usually. When we talk about scaling, it's usually about low resources, huge spread. And I think that's not that much applicable to the healthcare ecosystem. There is always an investment that we need to do as an ecosystem in order to make it real. And I think we are committed to that, Matthias.
Super. Thank you so much, Dr. Velasco. And now we move to the third question. Another reminder, we have already one question coming from the outside, so this is working.
Good.
This is good. We are in the digital session, so it should work. Third question and last one, and then we start with the question from the audience. Dr. Cosio, what are the 3 key success factors you make this your project happen in your hospital?
Well, there are 2 questions. If it's the implementation of value-based healthcare in my hospital, another is the implementation of the H2O project. I will start with the implementation of H2O project. So what I really think that will help us to make that a reality is the different approach. So from my experience, I was training in preventative medicine and public health, and I'm very strong defending the public health sector. Mm-hmm. Then when I started to work in this project that was a partnership with the private industry, of course I have that. And I have an idea how things had to be done. When I start to work with the private sector, it opened my mind. Then I think that is a case of successful, because things that I thought that's impossible, we're not gonna do that. With the public sector, never gonna allow to do that. For example, to establish a legal entity that will be different to the public sector. Then all these kind of things from my background, probably I was like, and I think that I opened mind, but it showed that not really. I was like, no, we cannot do that, we cannot do that. With all the other partners, all the other colleagues kind of said, what we don't try this, why we don't try this, then it's kind of made you think out of the box. Then it's when you see that project, like that's complex, it's in our ecosystem here in Catalonia, in Spain, it's difficult. We achieve things already that before I thought it is impossible. But it is possible because this different approach, with all this knowledge that come from the private sector and combined with the public sector, that really leverage and really help us to change our mind. Then I think that it is the main successful factor.
Great, thank you so much.
Well.
So, Dr. Feu, key success factors.
Yes, I think the three key success factors, the first one is leadership. It's essential to have the leadership of clinical team to develop this kind of project. With no commitment from clinical team, we think it's not possible to do one project like that. The second one is user-friendly. I mentioned it in my presentation. If the new registration of clinical data is time-consuming for clinical team, and they have no feedback from their work, they will not use this e-form to collect data. Then it was important for us, and we adapt the IT tools to make it easier to register data and offering to the clinical team as much as data from patients that they need in the decision-making process. And the third one I mentioned also in my presentation is the integration of clinical and patient-related outcomes inside the health information system of our hospital, not out of this system, because then I think clinical team will not use this digital transformation to treat patients.
Great, thank you so much. And Dr. Velasco?
So thank you so much. I could say we need to develop further this common language that we need to start speaking. And I also wanted to thank you, my co-speakers, because I think that you really made the point. There is a lot of opportunity in learning from each other, but we need to start talking the same language, and we come from the same ecosystem. The thing is, how can we really leverage value from finding this common language? Second, I would say we need the same definition of needs. Sometimes it's difficult to talk the same language, but music is common to everyone. And for me, there is a lot of noise when we are talking about not a clear definition of need, when we are talking about a project. But when you see a real need, really well-defined need, with patient involvement, with clinicians involvement, with payers involvement, that sounds like music. Mm-hmm. And there is a common language through that, which is more the differentiation of noise and music. And finally, I would say we need to be together in value. I think that's success for us, and it's one of the biggest barriers also at the same time, like being together in value. This means doesn't matter who you are, doesn't matter if you're an SME, startup, big capital ecosystem, an industry, a hospital, a private hospital, a public one. If the value is what you put first, then we can talk, and then we can make projects like the one that you were presenting. So I think that's the most important thing.
Okay, thank you so much, Dr. Velasco. Let's continue with the music. I have here three questions, and probably if you want, we can alternate one question from the outside and one question from the room, no? And we can. And in fact, I have here one question for each one. So let's start with one of these iPad questions, and then we jump into the real world. So the first one is for Dr. Cosio. How many patients are expected to participate in the project for their input and data to be of significant value?
We don't have exactly the numbers of how many patients. What we expect is to have answered in our different hospitals that will be around 80% of the answers. So we did an initial calculation of what was the figure that we have in our hospital, and with that, you have a strong enough for the statistical calculation. So far we don't have exactly the number. We have this percentage that we are playing with that, but I think that later with the scaling up of the project, all this number will be increased, and it will give more statistical support to all the results.
Okay, thank you. So now, is there any question from the audience here in the room? Or should, okay, we have one question there, and there is a micro coming to you.
Thank you. This is for Dr. Cosio. Two questions. First one is, I believe that you are using federated data in all the projects in all countries. Yes?
Yeah, this is the idea. We're not implementing yet, but how we defined the way to organize that is with federated data. And we participate in another kind of grants, for example, IHEDEN and OMOP, that also work with federated data. So the participants of the consortium are ready for this kind of sharing data.
Another question is, do you think that using federated data will diminish the problem of data confidentiality and RGPD compliance in different countries?
Yeah, I'm convinced that this is the way, and we are that what we're going through that road, because we also discuss another ways and the benefits or not to have other kind of sharing models, but they have some RGPD problems specifically for the interpretation in different countries. Then we all agree that the federated data is the better way.
Thank you.
Okay, so let's move to the virtual world, and now the question goes to Dr. Feu. Dr. Feu, what is the best way to motivate the patients? They answer, I imagine, to answer the questionnaires at home.
I don't know what is the best way to motivate patients. Probably there are different ways to do that. We have experience with this standard set of inflammatory arthritis. These are young patients, a set of young patients, and it's not difficult to get the commitment of these patients to be adherent to these new devices, to answer the quality of life test. Here, I think also we have a clinical team, an enthusiastic clinical team that I'm sure they will convince patients to do that. For other situations, we have to adapt our tools according to the set of patients, the characteristics of the patients, and probably we need to change where to answer quality of life tests. Probably in the hospital before visit, we're helped by a nurse, but we have different. I think we have different measures to convince, to stimulate patients to answer the quality of life test.
Dr. Cosi also wants to share her thoughts.
Yeah, I completely agree with Dr. Feu. Definitely, to make that easy for the patient is a very strong point, but also to make that important for the patient. If the clinician team recommend, and all this that you see, as you say, definitely, but it's more than recommend. They have to say, okay, you have to do this blood test, you have to take this pill, and you have to follow this questionnaire. Because all of that, we're going to see in the next consultation, how are you going with all these three things. It has to be a tool for care. It's not something like could be used for research, it could be for something, it will be good, and because we have a good relationship, let's do that it will be good. No, good for you. So in the next consultation time, it is important that they come with that. If they come without that and nothing happen, then it's a circle, nothing going to happen next time. But as a clinician, you don't imagine that you will see a patient with diabetes without see the blood test about how is the evolution of that. It's the same with the question. It has to be a tool of care. Then I think that maybe this is easy and important, maybe summarize the two things.
And may I introduce some idea here, which is when we were talking that we fall in love of the solution, it's exactly that. So we were implementing a prompts and prems questionnaire for what? To give feedback to the patient and to improve patient life. So if we provide them with feedback, and if this feedback is instant to the moment where they provide you with data, the faster you provide feedback to the patient, the most value they feel that this questionnaire has, which in proms and prems is a barrier, because when you have a lab test, you have a result from this lab test. Sometimes when we ask for questionnaires to patients, they don't get anything back, and if they don't get anything back, then they don't comply. They don't follow instructions if they are for nothing. Then if they have, for example, recommendations, or they have follow-up, or they have a feedback from what they are reporting on the system, they usually are more satisfied, because we don't forget about the purpose of prompts.
It's true.
And this helps. We've seen that helps.
Very nice thoughts. So any questions from the room? Yes, there is one question. Yes.
Hello, I am Vanessa from the Portuguese administration of the health system, and I have not one but two questions. One is for Dr. Cosio. You talk about this H2O project, and I would like to know if there is any chance for other countries to join and participate, and what can we do? This is the first one. And the second one is for Dr. Cosio again, and for Dr. Phil. So I listened to these projects, and I understand that they are feasible. So I would like to implement it in Portugal as well. But I am at the national level. So how can we at the national level incentivize these kind of projects? Thank you.
Okay, thank you for the question. I will start with the first one. The consortium, the IMI consortium, is made for 5 years. So during these years, all the providers that are working with this grant are the only ones that will participate in the observatory. But what we are doing is parallel working with other countries, other providers, to try to standardize and to hear their voice about how it has to be. So they don't participate in the consortium, but they help us as a board, advising board, to define how it has to be for the time when the IMI project allow us to open to other providers. It could be easy and it could happen. So basically, if your country or your hospital, you are at the national level, are interested in participate, what I suggest is to contact, to start to be part of the discussions. Of course, there is no money in the grant for you to participate, but you open for hear all the discussion and to know how things are going. For the moment when it will be allowed for different countries, you will get into in more slowly and smoothly way. So the second question was how to implement from the national level, during the national level. Yeah, this is the question always. How do we start with value-based healthcare? Then, what does the equation? The equation is with cost. Then, do we start at the regulatory agency or the national level? Will start to pay per bundles of outcomes? It could be a way. Also, another way is starting from the providers, for example, that the CEOs and the executive board will be so convinced about change and say, okay, we're going to start, yes, or it could come from the clinician. Then it's like 3 levels. It could come from the very, like in your case, also the clinician, they very motivated and say, we want to start. Then what is the right way to start? I say that a combination of all of that. So my humble recommendation, if you at the national level, start to pay per bundle is the way, but you have to do that in a very close conversation with providers that also believe that value-based healthcare is the way. Because if not, they will leave that like, again, is this national level giving us harder or more work because they don't know what we are doing here with the patient. So you identify clinicians, organizations, executive board that are committed with that are inspired about that. I think that a small pilot with them is the way to start from the national level. I'm not an expert, but from 4 years experience of implementation from the clinical, from the provider point of view, I think that it could work.
I agree with Dr. Jose. I think it's not it's not only a local initiative. I think many hospitals in our country are working in the same way, in changing from volume to value for patients. And I think that first we have to demonstrate that it is possible to implement this method, this new model, and to convince the organizations to put this model in a higher level.
Okay. Thank you so much, Dr. Feo. We are 1 minute to go, and just to honor the question that is coming from the outside, Cesar, you have 30 seconds. What is the future ecosystem in healthcare like?
So the future healthcare ecosystem, I would say, is about value-centered solutions and not volume-centered solutions. For that, I guess digital healthcare reimbursement or value-based healthcare procurement should be in place in the future, in the near future, if that's possible, as Germany or France are doing right now. And then I would say common language, a lot of music, and being together in value.
So with the music of Dr. Velasco, thank you so much to the audience, thank you so much to the speakers, and time is over. Thank you so much for the session.
Thank you.